of our. So welcome everyone to our community of practice on North Carolina Medicaid and postpartum policies. I'm so excited that we are going to get to have some special time with Tina Sherman and Velma Villalon. Taormina. Okay, I just messed up your name. Can you say your last name for me? Because I'm nervous because we just pushed record.
No problem. Velma Villalon, Taormina.
Taormina. Thank you. Really excited to have them both here. Dr. Taormina is passionate about empowering others to take charge of their health and focuses on the intersection of women's health and public health. She moved to North Carolina, Orange County in North Carolina in 2019 to focus on policy and advocacy in this space. She is our women's health consultant to several groups, including in North Carolina Department of Health and Human Services, Division of Health Benefits, where she's the Associate Medical Director Consultant for Women's Health. And she's serving as her second year as president of North Carolina's OBGYN Society. I didn't know that, that's cool. Tina Sherman is the Senior Campaign Director for the Maternal Justice Campaign at MomsRising. And she's dedicated her professional life to supporting and empowering moms and families. She has served as a legislative aide in the U.S. Senate, has worked with several child and women's organizations, is an active advocate on the North Carolina MomsRising Steering Committee, is a certified birth doula, and has made regular appearances at my policy class at the School of Social Work. Always a favorite among students. I skipped over a bunch of intro slides in my excitement about our guest speakers. So let me go back. Thank you, Suzanne, for always preparing beautiful, organized slides. Again, welcome. That link is in the chat. Again, if you would please complete that or use the fancy QR code. We are already recording. And look at these beautiful pictures. And then this is for the evaluation. So at the end, giving us feedback is always helpful so we can continue to improve. And so now I'm going to turn it over to our folks. Are you all good with, I will watch the chat. If you all have questions, we can put them in the chat. Tina, do you want people to raise their hands if they have questions while you're talking, or how do you want?
So I complete apologies to everybody, but my hotspot quit working for some bizarre reason. So I'm on my phone, so I'm not going to be able to see the chat. Okay. But I encourage people to come off mute and feel free to ask questions, and I'm happy to answer.
Awesome, and I will keep my eye on the chat for you, Tina.
Thank you.
All right, turn it over to you.
Oh, I have to come off mute there. Thank you. So good to be here with you all. Again, my name is Tina Sherman. I'm Senior Campaign Director with MomsRising. And as I was looking at who is in the room, I think many of you might be familiar with us, but in case you are not, we are a national, on the ground and online organizing force for parents, moms, dads, aunties, and anyone who has a belly button or loves or has a mom. And you can go ahead and move forward on the slides. We have over 1 million members across the country, with 40,000 plus here in the state. We have a state moms force here representing parents from all across the state, all across the county. I'm sorry, all across the state, all 100 counties. And you can go ahead and progress the slides, please. Go ahead. We work on what we call our layer cake strategy. And this means that there's several different ways for citizens to engage in as many ways as citizens are able to engage. We recognize in working with parents that they are incredibly busy, and we want to make it as easy as possible. And so we offer a variety of different ways for parents to, send a quick message to their lawmaker or decision maker, make a quick phone call. If they have a bit more time, to send a story. If they have a bit more time, join us in a visit with lawmakers, or even testify before Congress or down at the legislature. And we do none of this in silos. We work very, very closely with partners across the state and across the country who are working on issues that we work on. And to that, you can move to the next slide. And these are the areas of issues that we work on. Really, anything and almost anything affecting families, from workplace justice, workplace policies affecting parents, to early learning. Maternal justice is the campaign that I particularly run, working in maternal child health, and gun violence prevention, just to name a few. Go ahead. And I'm gonna move quickly through these slides, because I know that most of you on the call understand where we are where North Carolina ranks, and where the country ranks when it comes to maternal child health. But just to quickly again, we have a D+ rating from the March of Dimes, and really hoping MomsRising's real aim is to push for and advocate for policies that will really help to move the needle on our prematurity rate and our maternal mortality and morbidity rate. You can move to the next slide. And we are particularly concerned about the racial disparities. We know that Black women are 3 to 4 times more likely to die from pregnancy-related causes than white women across the country, and here in the state, 2 times more likely to die due to pregnancy-related causes. And you can move to the next slide. I think one of the most appalling parts of this is that we know that at least 60% of maternal deaths could be prevented with changes in policies. And so that's one of what we're advocating for. Next slide, please. So gosh, breaking news. Anyone who sits in a room with me knows that one of my biggest policies that we're advocating for is Medicaid expansion. And again, all of you know that in this room that most prior to these last few months, most women were losing their medical coverage at 60-day postpartum. And we've had significant changes in the state that we were just talking about as people were coming on, discussions around Medicaid expansion, excited about that. And across the country, COVID funds have allowed for expansion of Medicaid, and we're really hoping to make these expansions permanent, not only here in the state, but across the country. Next slide, please. So as of April 1st, North Carolina postpartum Medicaid coverage was expanded from 60 days to 12 months. And most recently, the Biden administration helped to expand access to postpartum Medicaid to nearly 250,000 Americans in 14 states and DC. So we're incredibly excited to see that movement as well. Next slide, please. We know that studies are showing that doulas can play an important role to help impact and decrease mortality and morbidity. Doulas, as many of you know, I know there are some doulas here in the room, can be a really powerful support system for moms as a part of their birth team, whether in the hospital, a birthing center, or at home. Studies have shown doula decreases the overall cesarean rate by 50 to 60% and the length of labor by nearly 25%. And we know when it comes to reducing racial disparities, doulas can really help play an important role in decreasing the mortality and morbidity rate. Next slide, please. One of the other really important policies that we are advocating for is paid family and medical leave. We know that 1 in 4 moms must return to work within 2 weeks of giving birth. And here in the United States, we have 0 weeks of paid leave. And Papua New Guinea are the only states in the are the only countries in the world that do not have access to paid family and medical leave. Next slide, please. So very, very sad, Karen. I can see, I didn't know how that was going to go. I can see the chat. Thank you. So one of the things that we're really advocating for is that we're advocating for a paid family and medical leave program that's accessible to all workers, offers a meaningful length of leave, and is affordable to workers, employers, and the government, is inclusive when it comes to defining family. And studies have shown that in states that have implemented paid family and medical leave, that it has a significant impact on maternal and child health outcomes. And so this is absolutely one of the policies that we are advocating for. Next slide, please. So for those that don't know, just a little bit of history on paid family and medical leave. So FMLA passed in 1993, and just a little historical perspective, Jurassic Park, the original Jurassic Park, also came out in 1993. I can't tell you, my kids could, how many reboots of Jurassic Park, but I can tell you that I just attended the newest one just a couple of weeks ago. So here we are, 25 plus years later, and we've had no update to FMLA. That was the first, it was meant to be the first step. We are incredibly grateful that it does offer protection for workers who to be able to take off for medical purposes, but it is unpaid, and so most people who even qualify for it are not able to take the leave because it is unpaid. Next slide. So while we have not had a significant reboot, we have had some significant progress over the last, I'd say over the last decade or so. And actually just in the last 5 years, we've had significant moves. So the Federal Employee Paid Leave Act passed. And I apologize, the pandemic has got my years all jumbled, but just prior to the pandemic, 2019, that passed in December of 2019, offering federal employees the ability to take paid leave. And then shortly after the pandemic began, the Families First Coronavirus Act, the first aid package included a provision for paid leave as well. So we know that there have been statewide movements, but we're also excited about the federal movement that has happened as well. Next slide, please. Excited to share that here in North Carolina, we introduced in 2019, introduced the first paid family and medical leave insurance legislation here in North Carolina. This isn't a previous long session. It did not go anywhere, but we're really excited. It's the gold standard and really builds on lessons learned in states that have adopted paid leave policies, including New Jersey and California, Washington State. We really have taken sort of lessons lessons learned from their programs and put that into this legislation. So it really was a gold standard. And hoping in the next long session that this is something we'll be discussing as well. Next slide, please. And there's been some additional movement here in North Carolina that I'm really excited to share about. In 2018, Governor Cooper signed Executive Order 95 that gave state employees under his purview paid parental leave. And then it kind of had a bit of a spillover effect. We had cabinet agencies that also allowed their employees to adopted a policy as well, including those who are, it wasn't just, our Democratic governor, but also Republican-led agencies, which is, again, showing that paid leave is bipartisan. It makes sense. Really, really excited about that. And also our the colleges, the university and community colleges system also adopted paid parental leave for their employees. So really excited about the momentum and leadership there. Next slide, please. And we're also really excited that we have 22 communities across the state that have adopted paid leave policies for their employees. Again, just showing that this policy is important to communities. The latest one, well, actually, I should say before the last one that passed, was a little town in Western North Carolina called Laurel Park. I was incredibly excited to hear that they had passed the policy, and again, their mayor and their town council just thought it was good common sense. Next slide, please. So I realized that I don't think I put in, I'm going to get to pregnant worker accommodations, but I want to talk a little bit about lactation accommodations as well. Breaking news, I always feel like when I give a presentation and I can give breaking news, that's always a good thing. Last night, in Congress, in the Senate, Senator Merkley, one of the co-sponsors, the lead co-sponsor of the Pump for Nursing Mothers Act, took the legislation to the floor. It passed the House on a large bipartisan vote, took the bill to the floor of the Senate and asked for unanimous consent. Unfortunately, I can't share that it passed. I was a little bummed last night, but it was a huge step that, the Pump Act that provides workplace accommodations for pumping people and nursing people. It was a huge step forward that we, even having this conversation, especially in light of where we are in the infant feeding landscape right now and the struggles parents are facing. But we did have Senator Loomis from Wyoming objected to unanimous consent, and so we're not back to the drawing board entirely, but back to negotiations. And we have lots of great folks on our side. I do want to share that our own senator here, Senator Burr, who is ranking member of the Senate Help Committee, which is where the bill was heard. He cannot actively support the legislation because of his rank in the Senate and on the committee, but it did pass by unanimous consent out of committee. So that means that he really did support the legislation. So incredibly excited to share that. So we're still fighting for this bill. So stay tuned for hopefully updates. Congress is adjourning today, the 25th tomorrow, or the 24th tomorrow. So just for short 2 weeks, and then hope they're back to it. So we'll be back asking them to pass the Pump Act. And the pregnant worker accommodations as well is another piece that we're working on both here in the state and across the country. So you'll see here that North Carolina is one of only 4 states that don't offer basic accommodations for pregnant workers. In December of 2018, Governor Cooper extended pregnancy accommodations to, again, state employees under his purview. We were incredibly excited about that. We are still fighting for these protections on the state level, but we'll be back at that in the long session. It did not make crossover here in this short session, but it is also, again, pending a expansion of the current protections. Again, very, very, very simple protections, just being able to allow pregnant people to have a seat, have an extra bathroom break, when needed, or be able to carry a bottle of water with them while they're at work. Just very simply sort of tightening up what the protections are, taking out some of those loopholes. And again, this is another issue that Senator Burr has really stood behind, and so we're hoping to get Senator Tillis on board. Again, the Pregnant Workers Accommodations, it's called the Pregnant Workers Fairness Act in the Senate. We are hopeful that that is going to come before a vote here when the Senate returns in the middle of July. Next slide, please. So if you are now excited about all of these ways that legislation is moving, I want to share just a couple of ways that you can get involved. Consider including some of these items. If you're working with an organization, consider including some of these on your legislative agenda. Join MomsRising. Oh, I'm sorry about that. This is what happens when you're on your phone and you get a call when you're in the middle. I apologize. Please sign up. It's free to do. You'll stay up to date on when legislation is moving. We were able to send out a text alert yesterday when the Pump Act, as soon as we heard the Pump Act was going to be discussed on the floor, we were able to send out a text alert. We drove, actually it ends up over 800 calls last night in just a couple of hours. I was incredibly excited to hear that. 800 calls to Senate offices yesterday. Consider organizing a meeting with lawmakers. Again, we have some bills here. I know it's short session here in the with the legislature, and we were also talking about how they're trying to get out of town sooner rather than later. But as when they're back in the district, when the Congress is in session, or when they're back home, consider organizing a meeting and to discuss these legislative issues, and just sharing why it's important, both from a professional perspective, if you're comfortable with that, if you're not, from just a personal perspective, why these issues are incredibly important. And you can email myself, tina@momsrising.org, or our state campaign director, her name is Beth Messersmith. Her email address is beth@momsrising.org. So I think that's thank you, Sarah. I think that's that might be my last slide. Yes, thank you. So I really appreciate being able to share a little bit about where things are and what's moving. It has been an exciting, very busy few months, and I feel I actually got some messages today on pieces that are moving that I'm hoping to get some more updates on. So please join us to stay up to date, and I appreciate the opportunity to talk with you all.
Thank you so much, Tina. That's so much information and so much movement. And also, I, on my own time, am part of MomsRising North Carolina.org. It's a great group. So I don't see questions in the chat. I think let's turn it over to Velma, and then at the end, maybe we can have a discussion about a bigger discussion.
All right. Yeah. And Tina, I mean, it's just, every time I hear you speak, I'm just amazed by, again, just the amount of work that's happening out there and in the community. So, happy to continue to partner with the work that's happening everywhere. So So what I'm going to do is just basically just give, so I'm here just to give you more of an update on what is happening with the 12-month postpartum coverage extension from North Carolina Medicaid. So, I do want to say that I am a paid consultant to North Carolina Division of Health and Human Services Division of Health Benefits, known as North Carolina Medicaid, but I am not representing them here today. That allows me to give my opinion on the changes that have been made and how we can do more in the communities to get the messaging out there. So in case there are others on the call that don't know the back history with this change, the American Rescue Plan Act of 2021 is what, that offered states the ability to extend postpartum coverage to 12 months. And that, luckily for us, our North Carolina General Assembly approved that option back in the fall, and the governor signed it into law in November. So what that did is that put the wheels in motion, and that was put into place with an effective date of April 1st, 2022. So what I want us to do is to go back 3 months so that, if I can get my slides to advance. Okay. So what I want us to do is to go back 3 months to put us in place of what actually was happening with our pregnant members at that time. So, to be eligible for this new program change, they either had to be currently pregnant, which meant that now during pregnancy and for the following 12 months after delivery, they would receive these full benefits, or the beneficiaries had had a birth event between February 1st and March 31st of 2022. Although states were given the opportunity to go back retroactively 12 months, North Carolina chose to go back 2 months. And so that did include beneficiaries that were specifically in the Medicaid for Pregnant Women program, which we know is MPW. And then it covered all pregnant beneficiaries that were receiving Medicaid under any program that covered both pregnancy and birth. So the members were notified regarding this expanded benefit through the usual communication channels that Medicaid has in place for any program change. And the postpartum coverage begins on the date that the beneficiary's pregnancy ends, and now will conclude on the last day of the month of their 12-month postpartum period. So especially for those in MPW, I think we all knew that little saying, at the end of the month during which the 60th day falls. Well, now it's the end of the month during which that 12th month falls. And beneficiaries will remain eligible, even if they have circumstances that normally would have created a situation where they would be disenrolled. But in order for all of that to go into place, the beneficiaries had to let DSS know that they were pregnant, so that the due date could be entered into the system to establish that 12-month period, or that the pregnancy is ended if it ended early, so that they could, again, just update the system to be aware that that change was occurring. Now, there are some exceptions to the postpartum eligibility, which are pretty straightforward. If an individual requests voluntary termination of benefits, then they could be disenrolled. If that individual moves out of state, they would be disenrolled because Medicaid is a state-driven entity. But if that individual moves back into the state during that 12-month postpartum period and notifies DSS, then they are re-enrolled and will receive coverage for the rest of their eligibility period. If DSS determines through information that they gather that they were granted Medicaid coverage in error, then that would be a reason for somebody to be disenrolled. If somebody was eligible for labor and delivery only, so if you think of those individuals that had just emergency Medicaid, then that would be, they would not be eligible for this postpartum coverage. And then unfortunately, if the individual dies, then that would be the other circumstance. Now, I want to make sure we cover the term of birth events, because I think historically we always thought of postpartum coverage being available to individuals that had like term deliveries or, vaginal and cesarean deliveries. But it's really any birth event. So I've listed, just like the basic 6 categories that we think of, which are, cesarean deliveries, ectopic pregnancies, miscarriages, molar pregnancies, elective terminations or vaginal deliveries. So it is the end of any pregnancy, and that is done by notifying DSS by a verbal attestation. DSS does not need written proof that you were pregnant. So the individual just has to give a verbal attestation. The only time they have to submit written proof to DSS is if they have a multiple gestation, and that's to cover the additional newborns in the system. So if we look at the different types of Medicaid, again, I just want to make sure that everybody here is familiar with what we generally refer to as regular Medicaid, Medicaid for pregnant women, and then emergency Medicaid. And then just generally, just to show that now with this new change, it doesn't matter whether they have what we call regular Medicaid or Medicaid for pregnant women, even though those are two separate programs because of the different criteria for income, they all now receive full benefits. So if you look at the MPW population, that's roughly about 2,200 individuals every month that deliver in that program. So regular Medicaid members already had full benefits for their full 12-month time period if they were not disenrolled. But now all of these individuals fall into that time period. And then emergency Medicaid, as a reminder, because they don't have coverage during their pregnancy, they do not get the 12-month extension of coverage. So, and the other point I want to make here too, that I hear a lot of confusion about sometimes is, so individuals that have regular, so 95% of the individuals that have pregnancy coverage are under one of the different prepaid health plans, one of the different standard plans. So they're, now you're either under the standard plans, or about 5% of those individuals stayed under what we call Medicaid Direct because they have one of the other types of specialty, what I call specialty Medicaid programs. But again, and that's important because I'm going to cover something here in a couple of slides for that. So this is just, a laundry list of what we mean when we say that they have full Medicaid benefits. And I think those of us that are used to working with the MPW program, we always think of the fact that, on data delivery, they no longer have dental services, right? They don't have vision coverage. They don't have, there's just so many things that would end after that time of delivery or after the 60th day. But as you can see from this laundry list, it covers every service that they will potentially need. And this is taken from the beneficiary postpartum fact sheet. So if you're not familiar with this new website, DHHS has a website called the Extension of Postpartum Coverage. And on the left, I did a screenshot that just shows you what that page looks like. But if you scroll all the way down to the bottom of that, you'll see these resources that are on the right side of your screen here. So there's a section that's called Resources for Providers, and that has a provider postpartum fact sheet and an FAQ document that covers all of the questions that come to us, either through forums like this or came through to us, through the open comment period. And then most importantly, though, is that there are resources for our beneficiaries. So there is a postpartum fact sheet for our members that are in English and Spanish. So especially those of you that are out in our communities networking, with potential members or with Medicaid recipients, this is a great fact sheet to have because number one, it explains what the new change is, but then it also gives them phone numbers where they can reach out to these, call centers to get help if they're being denied coverage by somebody. I mean, even though we've got, we've done so many different ways, even though we've done so many different types of communications to the different providers out there, I know that there are still providers out there who don't know that MPW is now a full Medicaid program. So again, just to make you aware that this website exists. And then just to share, why is this important? I'm excited about the fact that we have this new coverage in place, but now we need to take advantage of the coverage. If we think about this public health emergency, our Medicaid recipients have not been disenrolled from Medicaid since the pandemic began, since the public health emergency went into place. So if somebody has delivered since March of 2020, they've had coverage this entire time. But when Medicaid has looked at utilization, less than half of those individuals have actually accessed care in general during that time period. And if you look at postpartum care specifically, I love this. I'm a visual learner. I love the map because it shows you in colors where postpartum care is happening. So if you look at the color key here, the green shows that those counties are seeing women for postpartum visits at a higher rate than those that are in the red colors. So our far western counties and our far eastern counties are slightly lower in postpartum follow-up than counties that are in the green, for instance. So we have data like that we can share that just shows. We know that through our previous pregnancy medical homework that we did some really good work in increasing access to this care, but we also know that we have a ways to go. So again, just if you see your home county there and depending on their color, we know that across the state we have work to do. So we want people to take advantage of this. And when you look at the different issues that are there, on one hand, you have patient level barriers, you have providers level barriers, and you have system level barriers. But if you look at just the patient and providers, from a patient perspective, life happens. New moms automatically will put themselves on the back burner. They make everybody else a priority. And as Tina was alluding to, if they're having to return to work early and they don't have that built-in leave, there are so many components to that. But we also know that childcare and transportation are potential issues. And I'm going to show you something following this that will help with that. But there are some things that we can help them with. And then other things that, revolves basically around education, ensuring that they know how important it is to make themselves a priority so that they can take care of their health now that they have this new benefit. So when you look at things that are like childcare and, cell phones and transportation things, one of the things that we know our members are not taking advantage of are what we are called the standard plan added services. So on the left there, I did a screenshot of the healthcare option guide that's online that I don't know how current it is, but that was there from last summer. And that basically shows these are all the added services that a member has available to them depending on who their plan is. So on the right side, I just highlighted some of the things that WellCare offers if they are, if I'm an individual of reproductive age. These are the added services that I could take advantage of. Whether it's a GED voucher, there's up to $450 in rewards for baby products, strollers, playpens, car seats, diapers. There's different gift cards for different things. There's discount cards. There's a 24-week voucher for Weight Watchers. There's money that can be used for over-the-counter drugs, cell phones, with limited time. But again, if not having enough minutes is interfering with them being able to do a telehealth visit, for instance. There are tools that these companies can provide to their members to help them do that. And then lastly, from a transportation standpoint, all of these plans have to offer transportation to their members for any type of healthcare needs. So again, these are called added services, and depending on which company a member enrolls with will determine what these added services are. So it's great that they have these in place, and each of these companies are supposed to be reaching out to their members to educate them about the fact that these services are available to them. But we know just from our focus groups with different members that they are not aware of this. So if you're out in the communities working with individuals, again, making sure that you're helping to spread the message with that so that we can have them take advantage of these different services. And if we look at things from a provider standpoint, I know that I've covered this, in other sessions with just providers, but, again, I'm always, telling our provider networks, we have to make sure that we are not creating barriers in our own systems and walls that are keeping individuals from coming back in. And I always harp on that universal welcome. It's not enough just to have a physical space that makes somebody welcome. It also has to deal with everyone that's interacting with these members on the phone or through the online portals or through text messaging, making sure that you're listening to their needs and that you are engaging with them in a way that makes them want to come back in to see you. And I'm not going to touch on all of these just so we have time to cover some questions and stuff. But again, just looking at your clinical protocols, does your office know when you want to see these individuals back? We want you to see them back within, at the most, 2 to 3 weeks after delivery, so that you can do a comprehensive postpartum visit, so that you can identify what are their needs for that next year, especially because we have this new benefit. We need to identify the needs so that we can make the appropriate referrals and get them into that new case management, or establish them with a primary medical home, so that we can make sure that especially any chronic medical conditions that behavioral health concerns, that we can identify the issue, make a plan, make the referral, and take advantage of the fact that they have this coverage for them in the next few months. I've just briefly listed, when we're talking about what do we do when we bring them in, sometimes it's an incision check, sometimes it's a, blood pressure check, but to bill for that S code and to say that you've provided a comprehensive postpartum visit component, a comprehensive postpartum visit, these are all of the things that you should be covering during that time period. And again, not all of these things are going to apply to everybody, but just making sure that when that person is in front of you, that you are reviewing their specific history and that you're listening to their concerns, what do they think their needs are, and making a custom plan for them so that we can, take our work forward. And again, it goes back to reproductive life planning, right? If someone is planning a future pregnancy, then having that conversation with them about what needs to happen in the next 18 months to put them in the best physical and mental health that they can be in as they go into a new pregnancy. Or if they've completed their family, then what type of potential long-term chronic medical conditions are they at risk for, so that we can get them established with a primary medical home that can start to work on those concerns. And again, the bottom line is, if we have a beneficiary who becomes pregnant while on Medicaid, she needs to communicate with DSS about the fact that she's pregnant, or when the pregnancy ends. If her due date changes, especially if her due date is, for instance, instead of July, it's now August, she needs to notify DSS about that new change, because we want her to take advantage of that additional month. As a reminder, all pregnant people that have delivered since March of 2020 are still covered under full Medicaid during the remainder of the public health emergency. So even if they didn't fall into this nice window of delivering after February 1st, we want them to continue to engage in care. So if you run across somebody who had a baby 18 months ago, still having that conversation with them about, hey, are you current with your own, medical needs? And then making sure that when we are interacting with beneficiaries, that we identify any needed, medical care, and that we help them establish a primary medical home. So I know I've covered a lot of stuff here real quick. And again, the messaging is, we have this benefit, we need to take advantage of it. I could not see the chat while I was doing that presentation. So
I have my eyes on it.
Yeah.
Lots of people, me too, thinking that map was great. And just wondering if there would be a way to have access to the slides.
Sure, absolutely. You can share them.
Awesome. So we have a question from Kristen. Do you want to just go ahead and ask it yourself, Kristen?
Sure. Well, thank you. And we have shared interests in enabling people to utilize value-added services that are already available. And so I just wondered if you had more thoughts on strategies that are promising to increase awareness and then utilization.
No, I think that's a struggle that all of our payers have, right? I mean, I look at it from the perspective of, here we have, I take my own personal insurance, right? I mean, my insurance company is making money off of me every month with the premiums that I'm paying, right? Sure, they're paying out on my benefits, and even my company has add-on services. But if I don't access them, then that's savings for them, right? I mean, that is helping their bottom line. So on one hand, we have these great benefits, and each of the standard plans has a communication tool or plan. What would you call it? I mean, they've got ways that they each are communicating with their respective members. But we also know when we talk to individuals that have Medicaid, hey, did you know that you have this available? You get that blank stare back, right? So there, and there's so many different ways to communicate today, right? I mean, whether you're using social media or texting, Medicaid has to follow their set communication tools that are coming down to them from the federal level, right? I mean, they can't, they couldn't do anything different for 12-month postpartum extension than they do for any other change in any program, right? That's a set plan. But that's why we've engaged stakeholder groups. That's why we come to groups like this, where these are the thought leaders across the state, making sure that everybody on this, in groups like this are aware of these things so that they can go back to their communities and continue to spread the message. They've worked, they've engaged with community health workers and with, many stakeholder groups across the state. So, but again, it's one thing for us to have this conversation with you, but then now the next step is that you go into your own community, your own practices, and continue to spread the message. So, if I have somebody in front of me at that postpartum visit, I mean, that's, and one of the things that we tell our staff members, if we're working our tickler list, right? Like we know that these women delivered last month, and now we're reaching out to them. If I'm in a health department that doesn't do deliveries, then how do they know that somebody has delivered? Roughly 25% of Medicaid members have a delivery done by someone other than the group that gave them prenatal care. Like none of the local health departments do deliveries anymore, for instance. So how does that local health department know that their member has delivered? How are we going to get them back into the office, right? So making sure that the scheduler has this information, right? So that when they're on the phone with somebody, hey, transportation's an issue. Oh, well, let me help you arrange transportation to your next appointment, right? And so it's just continued engagement with stakeholders, and then having those stakeholders take that information back to their practices and their respective community groups to continue to get the message out. So
I thought your how you had the benefits by column for each of the groups was really helpful, because I think I could imagine how it could be challenging for a busy office to kind of keep track of that all. So that may be something else like that we as partners can make sure people see or have easy access to.
Yeah. And if you're an individual, if you go to the company's homepage, I mean, I look on there, every couple of months, and because that list is not up to date. I mean, they're always adding things or changing things. With the COVID vaccine, they added the an incentive card for getting a vaccination, right? So, I would encourage so yes, for your staff, it's important to have that one pager, but for your members, encouraging them to go check in on the homepage for their respective plan to get a full listing of that. And if they have children too, because there's things on there too, they're just for kids, right? So, but yeah, I mean, like right now they've got food vouchers that you can use at farmers markets, so you can increase the number of fresh foods and vegetables. I mean, so yeah, there's a lot there. It does take effort on the member's side to know that benefit is there and to take advantage of it. So.
Thank you. So we have a question from Doris. Can you confirm that if a beneficiary is covered by a standard plan, they are auto-assigned a primary care provider?
They are not. Let's see. So every person that is enrolled in a standard plan is automatically assigned a primary care provider. But if they have MPW, they start with MPW, and then after they deliver, they get assigned, if they don't choose their own primary care provider, then they have to work with their standard plan to get that done. Because, I'm going to use my home county, Gaston County. We didn't do primary care. So at the end of our postpartum period, we would hand them off to our local FQHC, which is where the majority of our members get their, use as a primary medical home. But if they started out at MPW, I will be on, I'm the one that's listed there, but then they will be, when they're ready to hand off to a primary medical home, they have to work with the plan. But everybody else outside of MPW, if that individual does not choose their own, then they are auto assigned someone.
Thank you. What other questions you all have? I'm curious about the data that you're starting to be able to collect, because, I think it's so helpful to understand who is using care or what services are they using. And it's a great way for us to continue to kind of look at equity. And just curious about what are your data plans or sharing those or.
No, Dr. Dowler, they have an extensive database. It's different than it was before, because now they're getting, I always get confused with claims versus encounters. The way they get their data is different now, but everything that Medicaid does as they modernize all of their clinical policies is based on equity. So they have a very robust system in place to capture, all kinds of demographics, social determinants of health. There's a wealth of information there. The part that I am waiting, I'm spoiled from the pregnancy medical home. We had such rich data available, not quite in real time, but pretty close, right? And with this new change, we don't have access, as a provider, I don't have access to that same type of practice level data. So I am waiting for the day that there will be more to share from that. Because like that map that I showed, I know that I can go in and run that on every day if I wanted to. But how that information will be shared back with the plans and with the provider networks across the state, I'm still waiting to see. We're not quite at a year yet, right? So I just have to be patient with the way data is going to come back to us in the future.
We've just only gotten started, and I want to kind of connect. Many of us in this group were in some conversation last December before this about what does success look like to us, and what are our own metrics of success. And so I think these, as we look and see what you're able to share, that helps give us some bigger vision for our state about how being able to actually have those ways of benchmarking change. So I think it's so exciting in your partnership and transparency and their transparency with data really matters. So I really appreciate that.
Well, for starters, proving to the payers that you are completing that postpartum visit is number one. And so you've got to go back to your billing and coding, because you could be saying, we are seeing all of our patients back. Well, number one, prove it. You have to prove it by using the right, billing codes, by the right diagnosis codes, right? So making sure that your office can do that. But then once you have that data, then what do you, and you internally know if you've got, 30% of your patients have cardiovascular disease, right? What are you doing with them in that postpartum time period? Who are you partnering with to make sure that they're getting the follow-up care that's needed? So there's ways that they can look to see who's engaged in care, that they're, looking at how they're going to capture that data down the road. But again, we're so new. We're not even 3 months into this new process, right?
Very exciting.
I know.
3 months in, but many people's dreams to get there.
Yes.
So Tina and Velma, thank you again so much. I want to call everyone's attention. We are going to be taking July off from our community of practice so that we can rest and restore, because that's very important for change. We have our next community practice is in August 25th. We're really excited to have folks from City Gate Dream Center that are going to be joining us to talk about quality postpartum care and support for Spanish communities. So that's going to be really Spanish-speaking communities, really exciting. And also we've got Medicaid expansion possibly. I mean, I just strike me quiet. So I think this is just going to be a lot for us to watch. I'd like to ask as we're closing, Tina, Velma, maybe Tina, what source do you watch to kind of try to stay current on what is going on in the General Assembly on Medicaid expansion? Is there a group that it would be helpful to follow just as people for us?
NC Child is who I kind of go to for late breaking news. Yeah, NC Child is where I go to.
Okay, thank you. So NC Child. And we have one comment in the chat too. Thank you, Kristen. And I think we don't quite have time to answer it, but I hope we can continue to have this conversation. Again, thank you everyone for making the time to be together. There's a lot of great things on the horizon, a lot of work ahead. We've got wonderful partners. And so just wishing everyone the best and continue to enjoy those gardens, stay cool, plan your vacations, and take good care of yourselves. So thank you all so much.
Good to see you all.
Thank you.
Thank you.
Everyone, this recording, I'll send that out. Bye.